Good morning. This is Dr. Arnold Feldman. And I thought today we would have a bit of a morning briefing for the chronic pain community, which I'm very active and concerned about. So I had my phone and I got a uh, alert or notification from the New England Journal of Medicine, which is a pretty good journal. Covers many aspects of medicine, but this particular article was a perspective called a perspective, and I'm going to put my reading glasses on. And the perspective article was entitled "Opiate Prescribing in the Midst of Crisis." Then hyphen Myths and Realities by Michael L. Barnett, MD. And I don't know Dr. Barnett, but this is dated March 19th, 2020. And in looking at this article, which I'll summarize for you, the opening statement is true, and he states the once simple act of writing an opioid prescription has become fraught, period, fraught with many things. So he then goes on to mention that physicians must check prescription databases, make themselves aware of the multiple state limits on dose and requirements of numbers of medications that may be prescribed for acute pain versus chronic pain. And he doesn't state this, but you must notate on prescriptions how or diagnoses, and that may be a state regulation or for insurance reimbursement and other things. And then he does not mention that there's always the danger of interference with your practice patterns by the DEA and their partners, the state medical boards. And those of you that know me, that I am on a crusade to reform the regulation of medicine by state medical boards, which has become a completely corrupt state of affairs. But the doctor writes this article, and it is a good summary, but I think a couple of things are missing. And let's go back to the conclusion. This is a short article. In the face of the overdose crisis, and I assume he means the opiate crisis, it can be difficult to remain neutral on the clinical appropriateness of opiate use, and that is certainly true. A key role for clinicians is to take responsibility for dispelling myths and for understanding the nuances of deploying these medications with appropriate bounds. Otherwise, polarizing misinformation will continue to carry the day. Opioids should neither be embraced as a cure-all nor shunned as universally dangerous and inappropriate. Like much of medicine, using opioids is both an art and a science requiring clinical judgment, shared decision-making, and compassion. So I like his conclusion, but if you read this article, there's some things that are stated that we disagree on. So let's just talk about the fact that we disagree. Doctors rarely agree on everything, as we know, and to disagree on clinical use of a medication is no more relevant. Is so relevant today in the midst of this coronavirus crisis. So those of you that have heard the news or seen the news about hydroxychloroquine. Hydroxychloroquine is a drug that is used primarily for the treatment of lupus. Chloroquine was used for treatment of malaria. And it was not a commonly used drug. It was used primarily for rheumatologists. Now, the treatment of malaria during military campaigns was a little out of my line, but chloroquine was used for this and given en masse to soldiers. But in clinical medicine in America, since I've been a doctor, it just has not been used except for lupus. So here we have the president touting the use of hydroxychloroquine for the treatment of coronavirus, and there are some people that say this is foolish, that there's no evidence. So don't they say that about opiates? There's no evidence. Well, the truth of the matter is there's lots of evidence about opiates. Opiates have been around for thousands of years, longer than any other drug, probably. Aspirin may be a close second. But there is ample clinical evidence to show the effectiveness of opiates. And so the problem arises is that the federal government, through its Justice Department, has now somehow or other taken the position that these drugs have scientifically been shown to be unsafe. Well, if you read this article by Dr. Barnett, that is not true completely. They are safe for most individuals, and a small number of people have side effects, and these are people with predilection for addiction. But what he did not mention in the article is a couple of things that I thought you would find interesting. So my background originally was anesthesiology. So the span of my career was anesthesiology and pain medicine. Anesthesiology, pain medicine, and minimally invasive spine surgery, plus interventional pain medicine, meaning injections, nerve blocks, epidural injections, radiofrequency denervation, implantation of spinal morphine pump systems, implantation of spinal stimulators, and other things. And then I learned through the years how to do laser-based disc operations. And so my experience is that I put people to sleep for just about every kind of surgery, and I have become an expert in the management of back disorders and chronic painful conditions from an anesthesiology point of view, and a pharmacology point of view, and an internal medicine point of view, which was my internship, and also a surgical point of view. But one thing that Dr. Barnett does not mention is that in the quest to relieve back pain, which is the primary source of pain, I think, for the vast majority of patients in a chronic pain setting, we, as physicians, try to recreate the design of the spine that we were born with, unless it's for congenital deformity. So in that quest, we have, over the past, say, 80 years, progressed to the point where we have become expert as a profession in operating on spines, but we have not become expert at relieving pain. And the one thing that is not mentioned in any of these articles, nor have I seen this, is comment or relevant comment from the surgical community on the treatment of the surgical failure, commonly known as the failed back surgery syndrome. So if you think about it, if a surgeon operates on a patient's spine, and does a good surgical job, meaning everything goes well and there's no perioperative complications in the immediate postoperative period, then the patient comes back, and if the x-rays look good and the patient says, I feel worse, tincture of time and some pain medication is the appropriate prescription. Hopefully the healing process will take effect and the pain medications will no longer be used. But what do you do with the percentage of people which is not 1% or 2%, it's more like 25% or more of the patients that don't do well with surgery? Well, to the surgeon, you simply operate again. And, in my field, I have seen patients with 10 and 15 back operations. So when is it time to put down the knife and use judicious amounts of pain medication? That's something that just doesn't seem to come up in these articles, even in a great journal like the New England Journal of Medicine. So the bottom line is that there's only one specialty in medicine that has a billing code for a failure to successfully treat the patient, and that is the treatment of back pain. And the name of they have invented a disease called failed back surgery syndrome. And those of you probably have heard of this. Now, if we think about it, if you're a cardiac surgeon doing bypass surgery or cardiac valve surgery, and you operate and the patient dies or does worse, you don't say they had failed cardiac surgery syndrome. You say, well, they succumbed to their heart disease, or we did the best we could and we couldn't get them any better, and their mortality is going to be high. There is no failed cardiac surgery syndrome. So what the surgical community has done is essentially blamed surgical failures, and I don't mean technical failures, I mean just the ability to recreate what God made. They blame it on the patient. And another interesting thing was that if you look at the surgical techniques, they tend to want to fuse the spine. Fuse the spine essentially means take a segment of spine that is mobile and make it so it is immobile. Now, if it does not fuse, meaning the bone never grows to fuse the spine, then if you ever smoked a cigarette, they blame that on the cigarettes, saying that there's evidence that smoking cigarettes reduces fusion rate. Well, so again, blame the patient. So basically, what Dr. Barnett says is true. There is controversy, but controversy in medicine has rarely been transformed to criminal prosecution and prison, which is what's happening to pain doctors. And so people in medicine, especially pain medicine, are prone to use the term chilling effect. And so basically what happens is when a doctor who is a compassionate person seeking good care for their patients hears about a doctor in Kansas, such as Dr. Hansen, or Dr. in Mobile, such as Dr. Pat Couch, or Dr. Ruan, his partner, getting 20, or Dr. Joel Smithers getting 40 years prison time for prescribing, and these are all over the country, those doctors that are still practicing pain medicine must be thinking, this is treacherous, this is walking through a minefield, and I love my patients, but I also am concerned about my autonomy, my freedom, my family. And so those doctors are going to be very reluctant to prescribe. And so what we need to do is we need to hear more vocally from the physician community because they're frankly afraid to open their mouths. And so that's my morning briefing. The article in the New England Journal makes some good points. It's neither anti-prescribing opiates nor pro Andrew Kolodny, so to speak, but it does make some legitimate points. So how is a doctor to navigate these waters? And that is yet to be determined. So stay safe, and the COVID-19 has taken the forefront right now, but the prescription of opiates, even from the patient point of view, for the patients on mechanical ventilation, is wanting, and there are shortages of medications, and these are all or should have been predictable, and somebody needs to be explaining this to the government, to the president, to us, to the voters. So stay safe, and we will talk to you soon.